Thank you, Florian, for your kind invitation. And also Sonia, I know Sonia is here, but also she's a tremendous help. Well, anyhow, tell her. Okay, when Florian asked me to talk about the EORTC guidelines, basically the European guidelines, I said, no problem. So last week I sat in front of my computer and say, geez, one slide, an algorithm, is 1 minute, or if I talk very, very slowly, it could be 3 minutes. But that's it, no more. So what I'm going to tell you is that the EORTC guidelines are very old, 2007, and Matti Apro is here. He is the chair of the new guidelines. So I was fortunate to be in the group of the working party. So I'm going to go through all the comments of the new guidelines. It's supposed to be approved and then published, as he told me, by ESMO next year, but probably at the end he'll talk about the publication of the new EORTC or ESMO guidelines in anemia. So that's basically the publication, and what we have 2006, and I update in 2007, so quite old. There's a paper, okay, and we keep referring to this paper, although we're 7 years ahead. So basically this was 2007, and the guidelines for EORTC, as you can see, are quite liberal compared to the other ones. Basically set initiation is ESAs, a concentration 9 to 11. So it's quite liberal compared to the USA colleagues. And the target is around 12. Not, as this morning somebody said, not 11.9, not 12.1, around 12. And the major goals of ESA therapy is, one, to correct the anemia. Second, obviously, to prevent transfusions, quite important issue. And third, quite important in Europe, but not accepted in the United States, is the quality of life. So those are the things basically that differentiate basically the quality of life and the start of the treatment with ESAs. This was basically removed, as like has been shown this morning, basically what I just told you in a nice table. Then we can open the rest of the tables at the end of the talk. See that EORTC considers 9 to 11 appropriate time according to the clinical conditions of the patient to start treatment with ESAs. And obviously, and also according to the conditions to start at 11.9, which makes the definition of anemia. And obviously, patients should be symptomatic, and the target should be 12, hemoglobin around 12. That's basically the standard of EORTC updated guidelines. I'm going to, there's these couple of things. There's no iron deficiency as a present, we can give iron supplementation. Now we know that it's better to give IV iron. And transfusions, minimal use. And that was the current, the published guidelines, which obviously are very, very old. And we're now used to put through what, which I think for this audience, the draft that the EORTC Working Party has elaborated, and we have a meeting every year, the meeting anemia, neutropenia, thrombocytopenia. At the end, we get all together, chaired by Dr. Apro, and we just advise new guidelines for the EORTC. So this basically what came out. This is important, but they put it, we confirm the quality of life can be significantly improved in anemic cancer patients following erythropoietic protein therapy. I know that with the audience there's somebody who will disagree with that. Dr. Grala is here. Well, Richard is here, will complain about that. And then the two major goals of erythropoietic protein therapy, a prevention of transfusions, and improving the quality of life with a grade A. All right, so this an upgrade, but that's the message. That's how we start with a working party. Changes we have made, not approved yet, ready to be approved and probably published next year, on when to start. Patients under chemotherapy whose hemoglobin levels are below 8 should be evaluated for needed transfusions in addition to erythropoietic proteins, plus minus iron. The issue we put 8, Marty, you can correct me, is that we find out when we were reviewing the guidelines that we have from 9 to 11 and then below 8. So when they said, what happened from 8 to 9? You recall? So what happened from 8 to 9? There's nothing. So we put below 8. Now, in symptomatic cancer patients receiving chemotherapy, treatment with erythropoietic proteins should be initiated at level of 8 to 11. So this is a change that we suggested for the reviewers to be incorporated in the new guidelines. Now, erythropoietic proteins may be considered in selected symptomatic anemic patients under chemotherapy with a hemoglobin level of less than 11.9 grams. So whatever you see with orange, innovations changes from the published guidelines from 2007, all right? And according to individual factors, type is intensity, chemotherapy, baseline, etc. One classical example for the guidelines that we always have a problem, you follow strictly to the guidelines, is always the clinical criteria of the physician is very important. Is a classical example of a patient with a head and neck cancer who is getting cisplatin. Probably because he's a smoker, the hemoglobin could be 17 or 16, easy. Then you give the first shot of cisplatin, can drop 3 grams, could be 13 or 12 and a half. You know this next time will be maybe 9 or 10. So in those patients, yeah, already symptomatic because those patients are used to have 16 and 17. To be around to 12, they're quite symptomatic. So that's why this freeway, this area for the clinical decision of the physician according to the symptoms of the patient. All right, and then we always consider early intervention because we know that early intervention corrects anemia faster. We require less erythropoietin, but this is not accepted. It's just a thought. Then we don't recommend prophylactic use of erythropoietin proteins to prevent anemia. It has been nicely shown this morning before lunch that the data came out negative. So that's clear, and we accepted that unless the patient is receiving chemotherapy, we should not treat just because there's anemia, and we don't know exactly the etiology of this anemia in that patient who's getting chemotherapy. Then, patient with cancer, selected patient with cancer anemia, not undergoing chemotherapy, there's something that we have to work it out. Now, again, treatment with erythropoietin may be initiated from 9 to 11, and based on anemia-related symptoms and careful assessment of the need. Those are things that presenting now are being evaluated to be approved, and they approve are going to be published. The target concentration is about 12. It's like a semantics here, around 12. Because you read some guidelines, it says that 12.1, 12.2 is the end of the life. Person's going to die of a heart attack or a stroke. And it's not true. You have a buffer area probably from 12 to 13, but according to the alarm, the FDA and all the concerns of ESAs, we just put around about 12. Now, we don't recommend dose escalation as patients not responding within 4 to 8 weeks. You recall at the beginning of the ESAs treatments, like around probably 8, 9 years ago, it was written even by the companies that if a patient did not respond after 4 weeks of treatment or 6 weeks of treatment, you should increase the dose of erythropoietin. And we're able to rescue probably 20% of the patients. Well, this is not anymore recommended. Now we have IV iron, we have other ways to do it. So we learn much more of that. So it's not recommended to increase, if the person does not increase the erythropoietin, so you should not increase the dose. Again, I don't want to bother you, the same thing, around 12. And then to try to titrate the hemoglobin around 12. And sometimes what I do is sometimes I just, instead of giving every week, if the hemoglobin is 12.2, 12.4, I stop it. And then I resume maybe the treatment after 2 or 3 weeks. So I give 1 or 2 weeks of no treatment to bring it below 12, and then I continue. So you also have to titrate the dose or the regimen of administration erythropoietin according to the needs and the level of hemoglobin. We don't want whatsoever ever go above 13. There's no evidence. This is evidence of increased response. If you give oral iron, Dr. Yves Begin this morning clearly shown that pure iron, that I used to give a lot, treats only the physician. I mean, the patient gets gastritis, constipation, and unfortunately does not increase the hemoglobin. So it's clear now evidence that we give IV iron is the way to go. We bypass the blockage by hepcidin into the GI tract, into the macrophage blockage. that's interesting because this paper is already, this slide is 1 year old, but I just kept whatever was part of the working party. Now we have 7 out of 8 published papers on IV iron, and 7 out of 8 positive for the use of IV iron together with EPOs, with ESAs. Okay, either erythropoietin alpha or beta can be used on a fixed dose in a weekly basis. The erythropoietin can be used every 3 weeks, also in a fixed, in this in a fixed dose, or 2.25 micrograms per kilo, or every 2 weeks. We don't use every 2 weeks at least in Europe, most of the places. Now, this is the algorithm that I was supposed to have put in the beginning, but this algorithm takes me 1 minute. So let's follow. Okay, so if a person has normal hemoglobin, prophylactic treatment is not recommended. If the person is symptomatic from 8 to 11, and when you see the red is what we have changed from the initial EORTC guidelines, consider ESA plus iron treatment, and then you can go to consider iron treatment, individual factors, etc. Then if the person has less or equal to 11 grams, you can consider, according to also person is symptomatic or not symptomatic. We don't want to treat a person with hemoglobin of 11 is asymptomatic. And then obviously if hemoglobin is less than 8, then we have to evaluate for transfusion need and consider to transfuse or not to transfuse according to the age of the person or the symptoms of the person, etc., etc., okay? So basically, that is the algorithm that we use in Europe, basically in EORTC, all right? Now, that's basically the precision party, like a summary, and with this I'm going to finish, is that one, we know the ESAs decrease transfusion needs is a major goal to start with ESAs in any patient. Hemoglobin levels are sustained on ESAs and not with intermittent transfusions. So there was a slide also this morning. They showed when you give transfusions, you could have a seesaw shape, up and down, up and down, up and down. When you give ESAs, you have a slow increase, then you reach a plateau, and that plateau is more physiologically. ESAs increase quality of life by European standards. Our colleagues from USA disagree with that. And then ESAs obviously should be used according to the guidelines. And I think that this is my end of the conversation, of the talk. Thanks a lot.